for Alistair. Earlier in the first session, we had Vasi talk about you know r- real time monitoring with pacemakers of patients who are at risk of falls and things. So I was just going to ask you about the synergies with the electroceuticals you were talking about, the remote monitoring and stimulation, and how that might come together.
Absolutely. I mean, I think there's really an explosion of these quantitative monitoring tools. And part of the problem has been, when people are asked to place, put a wearable on each day or continuously wear something, it's something they need to do all the time, and it's a reminder of the fact that they're being monitored and they have a condition. But what we're seeing now with telehealth and many of the technology companies offering devices through our phones, through our watches, it's becoming normalized. So I think that is the probably the major opportunity that people will accept to have this monitoring. And what we've seen with COVID has been there's been a great understanding of the trade-off, I suppose, or at least people have ventured into trying the trade-off of using digital health and telehealth and systems like that. And now they understand, what's on offer and how good it can be. Maybe we don't really understand some of the risks still, but we'll see those come along, and I think people will now have that option at least of choosing those sort of systems. Yeah.
Great. Thank you so much for those insights. There's, I guess, another question I have for Jinman, and this is sort of based on some of the talk that Lynn and Craig mentioned earlier on when they were talking about building up a data ecosystem. From my understanding, data is the biggest bottleneck for machine learning. So could you, if you were to have your dream wish list of data, what might that look like?
You sure you want to ask a dream question like that? I mean, what we are trying to do is to make data collection easier. And, every hospital, every department have lots of data, but it's about how do we actually use them without curating them or spending a lot of time to annotate and label them. And so we've been spending a lot of our efforts on what we call unsupervised learning, which is learning without labels. A small number of training data that can then be extrapolated and help to train the next batch of data. We've been doing batch-based learning. We've been building lots of semi-automatic tools so that as you actually finish interpreting, doing a routine case and you interpret and simulate your images, we would have our algorithm to say, hey, this is what we think is a good label for what you just looked at. And then you can just spend a little bit of time to fine tune it and refine it so that it can be used for training. And so we've been doing a lot to help make these data, I guess, accessible and useful for AI development. And so I guess to answer your question, the more the better, but then we are doing our best to make that as simple as possible for clinicians.
Yeah, hi. Thanks, Jim. And there's also another question that was just directed to you from Thomas. Not necessarily relevant to the biological side of things, but in terms of surgical application and being able to overlay it over the body, a major issue is to do with occlusion and accurate depth perception of the AR object in the anatomical position. So have you got any work on this end? And if so, how have you been able to overcome issues like the AR object occluding the site of interest or being perceived at an incorrect depth or incorrect positioning?
Great question, and it is a very important one. Thanks for asking. Firstly, we've been using holograms, which is a 3D object which has a 3D depth. So even though you wear it as a glasses, you do get a depth perception. So if you haven't tried mixed reality headset like the HoloLens, then it's quite, especially the first time, it's quite cool because you have a virtual object which have full depth and overlay to a physical object. And what we are doing is that because we are segmenting and creating label from the patient's image themselves, in this case, say CT or MR, once we can, what we call mount the virtual object into a physical site, then you get relatively good correspondence. And so this is what we are doing. We have two projects doing this technology. One is for the knee surgery, where we have CT segmented, and then we have a point of insertion for surgery. That's been detected as part of pre-surgical planning, and then we are overlaying the knee to the patient's body, and then seeing where that drilling point will be. And in that case, it's not really an occlusion issue, because we just have one side of the knee that we want to drill. The other is for rib fracture, where from the CT images, we detect where there's a broken fracture, and then we are overlaying the ribs to the patient's body itself. And that registration has been challenging. We are currently using markers, where we have 6 points that the surgeon will kind of touch on the patient's body, exactly where we want them to, which is ends of the collarbone, a bit of your first bit of your chest, the rib muscle, and then the last parts of the rib structure. And because we know exactly where those points are from your CT images, we can then automatically register that virtual object into the patient's body. And hologram gives you that kind of depth perception to give you confidence of where that ribs were. That's to answer your question. I mean, something like this, it would be so much better if I could show it to you, but hopefully that gives you some idea of what we are trying to do.
Thank you for that, Jinman. I think it suggests a visit to some of our research labs across the university and at the colleague. So there's another question from Alistair from David Hunter, who says, really like the physiologic assessment of gait. What sensors might be available to be worn externally that might be able to capture knee load to avoid the cumbersome gait labs and capture this in day-to-day life? Hang on, just...
Yep, I made the mistake of muting myself. I couldn't get back again. So that's a great question. I think that really, it highlights some of the information that we'd be able to gain if we could measure this, these behaviors outside the lab environment. Cameras, they'll record the external surface, maybe in 2D or 3D. And they can be, that information can be related through a biomechanical model to what load might be on the knee, but it's always a model, and those models, are based, not individual specific usually. I think it's really interesting to think about what we might be able to do with some of Jinman's and Ashna's work, for instance, in building an individual model from individual data, from MRI scans or whatever might be available. But another way to think about it, I think, is what happens biomechanically when we walk and at the knee. And I'm thinking of the electrical signals that we might be able to measure, thinking about how bone and other tissue responds to mechanical loads through piezoelectric kind of mechanisms. And I wonder if we could pick up that kind of information, thinking about some of the talks we've seen, perhaps with these nano robot type particles or something like that, could enhance that kind of signal if it wasn't large enough to measure anyway. So we might be able to envision having, if Elon Musk can measure what's going on in our brain with a sensor like that, I'm sure we can measure this on the knee. It's just about putting our heads together and I think coming up with a project. So that could be a good outcome of this meeting, to think about a project on doing that.
Thanks, Alistair. We have just another question from Vasi. What would be the implication of knowing more about knee load?
I think this is probably best answered by David. I mean, I worry about the pain I feel in my knees sometimes, but I think no, I'm better off not thinking about that and keeping active, because that's the that's the message I hear through public health messaging and other things. But it does make you think: are you pushing yourself too much? You think about someone who's maybe using the gym or training for sports, and they're thinking, is this pain telling me to stop, or is this pain that I should kind of not take too seriously and keep active? So.
Yeah. So, Alistair, I would love to have a conversation with you about measuring knee loads, and I think if there's a capacity to do this on an individual level, incorporating some of the segmented models that Jinman was talking about, I think that would be brilliant. Vasi, I think the thing here, at least from a physiologic and maladaptive purpose, is that we know that most of the pain, at least in knee osteoarthritis, is what we call mechanical. So that it's an activity related pain, and that they're doing an activity that is producing symptoms. And oftentimes that can be predicted, but oftentimes it can't necessarily be predicted. And so both from a preventive standpoint, in terms of identifying what triggers lead to activity related pain, but also better understanding responses to therapies where we're altering load. So, the modification of shoes, inserts into shoes, braces, things of that nature, where we know we can modify the mechanics of the knee. It may be advantageous to see what, if any, influence that's actually doing or having from a therapeutic perspective to injurious or maladaptive types of knee load. So it's both from a prognostic standpoint, but also from a understanding therapy perspective. But I think there's a lot of potential there.
Okay, thanks, David. And we're pretty much at time, so maybe we'll wrap up this session. And thank you all to the speakers of this session. And we will move on to the breakout rooms where we can have more interactive discussions among all of the speakers and participants in our workshop today.
And thank you very much, JJ and Ashnil, very much for chairing that last session. Just in terms of preparation for the breakout rooms, just so people have some comprehension of what's going to happen, there's been 3 breakout rooms allocated. Many of you have predetermined what breakout group you're going into, whether that be medical imaging, biomaterials, or biodevices. For those of you that haven't predetermined that, you'll be randomly allocated to those breakout rooms. You'll be in those breakout rooms for 40 minutes. They're chaired, so there'll be someone there capturing the ideas, the discussions, the interactions, and hopefully the fruitful collaborations that will emanate from that. The host in the breakout room will pick group participants based on the pre-suggested list. Otherwise, as I said, you'll be selected randomly. If you're having any problem or challenge getting into the breakout room, you can request the host to join that room. So just use that using the help or chat box. The host will get a prompt at 10 and 5 minutes to remind that there's going to be a closing of the discussion, and the host will actually close the discussion, close the session, and a timer will start to slowly take you back to the main session room. You'll then, after that breakout room, you'll come back and there'll be a debriefing of each of the breakout groups. Hopefully that's all reasonably transparent, and you'll now be, I guess,